The culture for me is all about our caregivers being able to bring their best self to work. We don't want them to have to feel like they have to care more, go above and beyond. We want that part to be easy for them so they can actually just bring their whole self to work and do what they do best. And that for me is making it easy for them to do the right thing each and every day.
Hi, I'm Chris Malone, and I'll be your host for today's discussion. Thank you for joining us. Today's discussion also marks the second episode in our program partnership with Planetree, so a warm welcome to listeners from the Planetree community. For those of you who may not be familiar with them, Planetree is a global not-for-profit organization dedicated to humanizing healthcare for everyone through excellence in person-centered care. So we have many shared aspirations. Today, we'll be talking with Dr. Leslie Jurecko, Cleveland Clinic's Chief Safety, Quality, and Experience Officer. Welcome to the program, Dr. Jurecko.
Nice to be here, Chris. Thanks for having me. Appreciate it.
To get us started, can you tell us a little bit about your role at Cleveland Clinic? It has kind of a unique combination of things included, it seems.
Yeah, absolutely. So have the unique privilege to lead safety, quality, and patient experience for the Cleveland Clinic, large organization, and get to have wonderful teams at each of our sites of care across the globe.
So is there a story you can share about how you came to work in healthcare or any memorable experiences that shaped your perspective on care?
Sure, happy to. I think we all in healthcare have some reason why we drive into that, go through the years of studying to want to be at the bedside. And for me, it's really a story of kind of suffering in family members, but also really great stories of watching healthcare find healing in those family members. And it starts when I was 10 years old. And believe it or not, I have a 10-year-old daughter at home. And when I look at her, I can't believe that I went through this trauma when I was little. And I'm sure it shaped who I am today as a physician and a physician leader. But when I was 10, I was out on a bike ride with my friend. And like we all did back then, we didn't have phones. And I think they just told us, come home when it's getting dark out or come home by a certain time. And so they never really knew where we went. My friend Kim and I went and got ice cream, and we were at the ice cream place. And sure enough, her mom drives up and says to me, "Leslie, your father has been in a really terrible accident." And I remember dropping my ice cream. And the first thing I said was, "Is he dead?" For me, as a 10-year-old, it was a very binary. Is he alive or is he dead? And she said, "It's very serious. We need to get in the car and head over." And where his accident happened was about 2.5 hours away from where we live. So we frantically, our family got in the car, my mom, my sister and I, we had some other family members join us, and we raced over to the hospital we thought he was going to after his accident. Well, sure enough, it happened to be a foggy day, and he had to go to a local community hospital to be stabilized, and then was brought to the trauma center. So we actually arrived to the hospital before he was there at the main hospital for care of his trauma. He was stabilized, but then they wanted to bring him and fly him to the main trauma center. It was too foggy, so he came slowly by ambulance. Now, I happened to be in the ambulance bay as a little girl when he was pulled up. The ambulance pulled up. I just actually went out with a family member to get a sweater because, of course, it was cold in the waiting room. And when the ambulance pulled up, he was pulled out on the stretcher. And I ran up to him, and his face, he had one cut across his nose. He was alert, awake, conscious. And I grabbed for him, but he couldn't move his hands. He couldn't move his legs. He couldn't move his feet. He was completely paralyzed, a full quadriplegic from a broken neck, severed spinal cord. But he could talk. And in that moment, he said to me, "Don't worry, be happy." And back then, that was the song of the year, "Don't Worry, Be Happy," if you remember that song. In that moment, my father, who should have been worried about himself, and the fact that I'm sure he was very, very scared, had just a grace about him and that empathy about him to tell me that, because we love that song together. So fast forward, he has multiple surgeries, a long rehab, 9 months in either acute care or a post-acute rehab facility. My sister mom cared for him. He lived 18 years, was a great member of society. He actually ran a business from his wheelchair, was a wonderful human being, but lots of ins and outs of healthcare. And I watched the suffering a quadriplegic man could have as he tried to raise his two daughters and be a family member and contribute to society. And to fast forward a little bit more, my mom was also diagnosed with cancer as I was entering college. My father was still alive, needing care. My mother needed a stem cell transplant for cancer, multiple relapses, about a decade of complications. They both died in my 20s after a lot of suffering. But what I saw was not only healthcare and how challenging it can be to navigate, just absolutely challenging. I knew from a little girl I was going to go into healthcare. Like I knew I had to fix this. I was just too. I don't know if it was frustrated or it was like the Kindle inside me. I just wanted to make it better for somebody else. But I also saw like amazing caretakers. Some of my father's nurses are still part of our like broad family. They taught me so many things as I was a 10-year-old running around that hospital. They taught me how to care. They taught me how to think outside yourself and really lean in with empathy. And we've stayed close with them over the years, and those relationships are very valuable to me. So that's a long story of like honoring my parents' suffering, honoring the way we went through that healthcare system as a family, and then also the caregivers that cared for both of my parents and what they deserve, which is a better environment to care.
Wow, that's amazing. A powerful experience. Really traumatic, I'm sure, in many respects, and I'm sure it shaped you in an awful lot of ways. Now, I've also read that your kind of inspiration is unlocking the hidden potential in healthcare organizations. I was wondering if you could kind of elaborate on that a little bit for us.
Yeah, sure. So Cleveland Clinic, just a few stats. We're 20 plus hospitals. We have a global footprint. So we opened in London. We've been in Abu Dhabi for a while. We have a footprint in Florida with 5 hospitals, many ambulatory sites, Northeast Ohio, of course, also Toronto and Las Vegas. So just a vast array. And there's 80,000 caregivers that work for us. And I love the idea of taking what caregivers come in with into healthcare, that passion to heal, but also the passion to improve someone's life in general, and tapping into that. And I really feel how we anchor to do that is through psychological safety. And what I mean by that is, I think these 80,000 caregivers truly do arrive with that passion. And when they see something and they want to either say something or they want to fix something, if there's psychological safety, they will go above and beyond to do that. If there's not, their mindset will be, why bother? Why bother going the extra mile, taking the extra step? It will either mean more work for me, I don't know how to do it, more hassle, it could feel punitive. So for me, unlocking that culture of psychological safety then helps our caregivers shift their mindset to always wanting to speak up, always wanting to be improvement ambassadors. I just think it's a huge loss to have 80,000 caregivers if they're not aligned around that purpose. And I love to unlock that feeling for them that they can be part of something better and bigger.
That's really powerful as well. It sounds like it really does start with the caregivers and the culture that they are brought together in, and everything else is empowered or enabled by that.
Mm-hmm. Yeah, absolutely. The culture for me is all about our caregivers being able to bring their best self to work. And I think it's been said probably on this show and other, we don't want them to have to feel like they have to care more, go above and beyond, jumping over the hurdles and extra hassles. We want that part to be easy for them so they can actually just bring their whole self to work and do what they do best. And that for me is making it easy for them to do the right thing each and every day.
You seem to have kind of a unique combination of responsibilities. Can you tell us about how quality, patient safety, and patient experience are intertwined at Cleveland Clinic?
Sure. So at the Cleveland Clinic, we really do see everything as high quality care. So if you don't have that great empathetic experience where you understood your plan of care and the communication was wonderful, then it's not high quality care in a patient's perception. So we really combine our efforts around safety, quality and patient experience together. In fact, it's structured together. So I lead all of those entities. And across the enterprise, we have decentralized teams at each of our locations that live and breathe the local culture there, but they're connected to our central structure, and we all drive the same strategy and tactics together. And then our goals. So we really focus on a few goals. And again, it's all combined for safety, quality, patient experience on a premise or a foundation of high reliability. So that promise to the patient each and every time we serve them. And that's around safe care. So preventing harm that reaches them in our complex system that could reach them, we want to prevent that. Improving our outcomes for them, or that typical quality of care. We want to be the highest or serve the highest quality of care to our patients. And then preventing, of course, any other complications that can come their way throughout their procedures or their care. And then finally, what we're measuring is a little bit of an atypical patient experience metric. We're measuring ease to get care. I think there's a lot of suffering in waiting, a lot of psychological suffering and harm in that waiting. And so we work really hard, though it's a challenge, definitely a challenge to increase our access to our patients, narrow that time to treat. So if they hear about a diagnosis or a concern, maybe on a scan, that we shorten that time to their in to either get their biopsy or a follow-up test. So all of those things around ease to get care at the Cleveland Clinic is something we're really focused on this year. And it's also on our CEO scorecard as well.
I think that you made a really important point there, and that this issue of time can really contribute to and amplify trauma, and that it can be a psychological, pain point in addition to all the clinical, physical pain that patients or family members experience. And that is something that I've often felt, sometimes when I go to the doctor, you feel like the doctor or the organization feels that my time is free to them. And so they're happy to use it in whatever way they choose without regard, to the impact it may have. But, with all of that as context, part of the inspiration for this program is that kind of over the last few years, it seems like there's been this growing interest in the idea that healthcare needs to become more human, perhaps even especially so since the pandemic. And I'm wondering what your thoughts on this. Does healthcare need to become more human in your perspective?
Absolutely. And I think I could say that since I was a little girl. Our business is the human body. It's the physiology and the psychology of the human body. And absolutely, we have to know our entire goal is to get our patients, that very being in front of us, either keep them healthy, or if they're not healthy, to get them healed and back healthy again. That's our business. And so I really feel like we have to be centered around the needs of each individual human. I will tell you, with healthcare and the way it's going, it has been a challenge. You've seen, and everybody probably listening has seen, some large healthcare systems get bigger. It's a environment of big acquisitions and mergers, and what you see in that is a call to standardize care. And as a believer, and absolutely will study high reliability all day long around standardization and driving out variation. But there's an element of you standardize where you can, and you personalize everywhere else for the human. And that can get lost in healthcare, especially right now with this massive desire to grow and be relevant. And so what I see in some examples is that they'll try to standardize a process everywhere. And again, that's a beautiful thing. But each person comes in different, with different needs. Either it's psychosocial needs or different needs, feelings. And so to try to standardize and personalize is really the fine balance that we have to make. And I really feel like that helps with humanizing healthcare. And I'll give you one example we did here at the Cleveland Clinic, and it finds that balance. So much of healthcare, when you do procedures, you go through a checklist. Just like if you're an airline pilot, you go through a checklist before the procedure, usually during and after the procedure. And you can hear, they're usually called timeouts or universal protocols. So we were working through, we're always trying to improve ours, right, to drive reliability. And we decided that it was so structured and so processed because it's a checklist, right? And we wanted to spread it across the enterprise and make sure everybody followed it. We lost the human in all of that, right? Do this, check this, make sure this isn't expired. And so what we added, and just kudos to the team for pushing us on this, what we added was at the very beginning, a moment to care. And that moment to care is an intentional part of the checklist. And what we're asking the care team to do there is very first thing before the patient goes to sleep for their procedure, or even if they're awake, to stop and ask the patient, talk to the patient about kind of what matters most to them. Ask Leslie about, does she have kids, or where does she work, or a moment, and just connect for a moment the entire care team to the patient and the patient back to the care team. And it truly is a moment of humanization that is a beautiful thing. And then they go right into the checklist, of course. But for a moment, everybody pauses and connects to the purpose why they're there, and that's the patient.
Excellent. Would it be an oversimplification to say that all of the clinical things we want to standardize, but all of the interpersonal things we want to personalize? Is it that simple, or not quite?
Chris, it's a good thought. I think even some of the personal communication things, though, we can absolutely standardize. I'm sure you've heard that on the show before. Some of we do start with heart and then ready to communicate. Very scripted, standardized kind of processes of how you should communicate. Smile, connect to the patient, use empathy, apologize. So I think that can be standardized to a point. But yeah, that patient is an N of one in front of us, and they come with a whole array, and it's not the same as the next patient. So that's the moment where we have to treat ourselves a little differently than the typical business that standardizes everywhere.
Got it. And so these changes that you've made and kind of start with heart, how has this impacted clinician engagement? I'm sure it has a very positive impact on the patient experience, but how
Sure.
is that kind of having an impact on clinicians as well?
Yeah, well, we've been teaching that for a long time. So communicate with heart, start with heart, and ready to communicate are some of our kind of toolbox communication skills that we put together, and we train all of our caregivers on it. We've evolved that over the years to align that, especially in the last year, to align that with high reliability. And the beauty of these skills is our caregivers can lean into them when they need them, if they need help with certain situations. But it also sets a tone for Cleveland Clinic of patients first communication. This is how we communicate with our patients. We do apologize. It's okay to apologize. We want you to smile, or we want you to develop rapport with your patients. So we give that toolkit for our caregivers to feel like they can tap into. And how we evolved it with high reliability, we added in the safety skills that our caregivers need to prevent errors reaching or defects reaching our patients. So now we really see high reliability is not only those typical skills you use to kind of check a medication and check this, but also the communication skills are part of that. And those expectations, so their behaviors and then tools that go along with those behaviors, have been taught in the past year to all 80,000 of our caregivers. Both clinical and non-clinical caregivers, really important piece there, non-clinical caregivers, they want to be part of this. High reliability expands into their world, certainly high expectations for communication when you look at our non-clinical caregivers as well. So we trained everybody on those pieces, and it's been great engagement. Chris, I'll add one more thing that we did that I encourage anyone listening that's trying to do something like this in their organization. We all know education is just a real starting point. So you can serve a module up to your caregivers, but that only takes you so far. And so what we did, again, brilliant credit to the team, is we started leader guided discussions. And every month we would teach a behavior around high reliability, whether it's preventing harm, a communication skill. We would teach those tools that go with it. And then we'd have all of our leaders. We have about 4,000 leaders across Cleveland Clinic. We train them up special for these leader guided discussions. Every month, they had to have a discussion with their teams. It was very much packaged for them around those behaviors and those tools. So it was not just an asynchronous learning on a module, it was a leader guided discussion that lasted 20 to 30 minutes on those topics every month. And here's also what we did. We had those leaders measured on it. So we had every caregiver say, yes, my leader had that conversation. And then they did an assessment of how that conversation went. Yes, it was important to me because I was able to connect to these high reliability tools. My leader taught me how important they are to use them in these situations. Those leader guided discussions, when you talk about caregiver engagement, have been so powerful that we're continuing them this year. We finished the 6-month kind of course of them, and we're starting the next. We're going to do them every month this year on different parts of our values, because it's been so powerful for that core management team to host these conversations.
Wow. And I was going to ask you, how do you kind of populate and disseminate these concepts that are fairly complex at such a large organization? And it sounds like, during the pandemic, in many organizations say, hey, we don't have the bandwidth or the staffing level to send people off to training sessions. What you've done is you've brought these concepts in on a monthly basis and have leaders guiding those discussions that don't take people off the unit or away from their role to kind of do that kind of development and training, all in alignment with one another. That's kind of a big idea.
Yeah, we've been really surprised. And we thought maybe we'd get 60, 70% compliance at the end of the month. If I had my dashboard, I'd show you it's 85, 90, 95% compliance, where the caregiver said that their leader had their conversation with them. We made it easy, QR code that the caregiver had the conversation. We packaged up all the tools for them. And we also said, do it on your regular scheduled meetings or huddles. We're a big huddle. We have tiered huddles. And so they would use their huddle time to cascade the importance of these behaviors and tools. And it's been really great.
Is it having a positive impact on engagement and retention? I know that many organizations are still struggling with nurse staffing and things of that nature. How is it working for the Cleveland Clinic?
Yeah, the good news is our retention has kind of leveled out and improved. So happy about that. It's hard to say if it's one-to-one because we're doing so much. We always say we care for our patients and our caregivers like family. And I truly believe we do. It's impressive, not just through the pandemic, but what we do for our own caregivers. We really lean in to treat them like a family member. And I think that helps greatly for retention and also engagement. I think when your leaders are having conversations with you about what matters most, I think the engagement is there. I do think it harkens back to psychological safety. Just having the conversation will open space for psychological safety. The key part of leader guided discussions is that they're bidirectional. So we really coach on that. And we ask that during the assessment that those caregivers tell us, was it a bidirectional conversation? We have a lot of open-ended questions that the leader asks the caregiver, and the caregivers are expected to speak up and talk about things. So I do think it's helped. We haven't measured our engagement. We do a pulse survey once a year, and we haven't measured it kind of since the 6 months. But I would imagine it would go up. It's hard to say if it's one-to-one because we're trying so many different things right now.
Yeah. You said something else really interesting is you think of the way you care for patients and team members as family. And there are kind of widely varying views on that. There are some people, that kind of speak that same language, and others say, no, your job is not a family. That's a task. That's a different kind of thing. As you know, I'm a big believer in relationships, not only in personal life, but in your professional life as well. And I imagine that those relationships that form as part of these leader guided discussions are part of what is enabling, that engagement and that retention.
Yeah. We've for a long time, and it's been led by our CEO, have always said, treat each other like family. And I think that means a lot when you're a leader saying that. We are such a high performing culture, metric driven, that we sometimes can forget to recognize all the wonderful things happening or to take care of each other as we drive to fix something else or drive to reach this outstanding performance. And so that message around caring for each other like family, of course, care for our patients like family, has been really powerful because on the other side, we're also saying, hit these metrics, be top decile. We are high performing. We are Cleveland Clinic. So it's been a nice balance on messaging for our caregivers.
Excellent. Now, recognizing that there are many organizations that aspire to be like Cleveland Clinic, What suggestions do you have for patient experience leaders that are really hoping to align their clinical teams and ensure that everyone's pulling in the same direction to deliver better experiences and outcomes? Any kind of rules of thumb or places to start that you would suggest?
Yeah, I think this is all of us that lead experience or safety quality experience are always trying to, make sure we connect what we're trying to do as an enterprise that matters most to our patients all the way down to where our caregivers are at the front line. At the Cleveland Clinic, we have a really powerful improvement model where we try to teach our caregivers, our frontline staff, how to do those, day-to-day improvements and use either a PDCA cycle or some type of improvement tool to make things better. But what we also found with our improvement model and with our goal setting over time is our caregivers were still arriving to the clinic or the hospital or to their ambulatory surgical center, and they weren't quite sure what to do that day to improve this top level patient experience or to improve something in the quality or safety realm. So over the last couple of years, we've been working really hard on those, I hate to call them process metrics, but those moments, maybe we call them, that you come in today, and if you do this, if you do, for example, a plan of care visit where you and the physician, so you as nurse and physician and care team, come to the bedside every day and have a meaningful conversation with our patients and our families about their plan of care, you will help drive our likelihood to recommend as an organization, which of course drives our brand, which is trust, and it's a virtuous cycle to all things growth and profitability. So we've been really working on today, work on your plan of care visits, because your patients, kudos to Dr. Adrienne Boise, who will be your guest next month on this podcast.
That's right.
She's just a visionary in patient experience, and she challenged the team. Every patient should have a plan of care visit with their physician and nurse and the care team every day in our hospital system. And that's how we care. That's our care model. We haven't arrived there yet. We've been measuring it at the CEO level for a few years now. And we're asking our patients to tell us, did their plan of care visit happen every day? And this past year, we asked them, so a patient reported metric, was it meaningful? Was it helpful to you? So the more quality of that visit. And we have a long way to go on both those, that they happen reliably. Because when they happen Monday, Tuesday, Wednesday, Thursday, Friday, the whole week, patients are really happy. If we just do those plan of care visits on Monday, maybe we do kind of one on Wednesday and Thursday, they're disappointed because they know our bar is set here. So we've learned a lot going back to telling our caregivers, today, you don't worry about likelihood to recommend or all these metrics that float here. Today, we need you to do this really well at the bedside. And that's been helpful for that engagement piece. It's not perfect, but we're trying, much like everybody else.
Well, that's great advice. And I understand that last year, Cleveland Clinic launched a new Cleveland Clinic Connected program, offering collaborative support to other hospitals and care providers to improve outcomes and experiences. How is that going? What are you learning from that process?
Yeah, so the Cleveland Clinic Connected program is really open to both global partners and national and the US partners. And the idea is, we've been at this for a long time. We have 100-year plus rich history of being a physician-led, provider-led organization, highly focused on safety, quality, and patient experience. Let us help you. Don't recreate the wheel. Let us partner with you and let us help. And the mindset really is, none of us should be competing on safety, quality, or patient experience. We should be doing it better together. We know today healthcare is not highly reliable there. There's too much harm. It's too expensive. The quality of care is not where we want it to be. And so the approach is really, let's share and partner. Now, and we're all over now. We've gone to many places, both Europe, Asia. It's been really wonderful for us to develop some partnerships. And I'll tell you what we've learned is probably as much from them as they have from us as we share. Across the globe, there is so many different kind of payment models and how the money flows through healthcare and how different populations perceive health. And so we've learned a lot from them on how to think about value-based care, how to deliver our care differently. And so it's been a great start to Cleveland Clinic Connected. Really excited to see where that goes.
Can you expand a little bit on your thinking on value-based care? What are you seeing in the future for Cleveland Clinic in that regard, perhaps building on what you've learned from those other partners?
Yeah. So value-based care, as a experienced leader, quality leader, safety leader, we have to be in it. We have to understand it. 1/5 of our GDP, of course, nationally is wrapped up into healthcare. And unfortunately, as much as we want our business to be about patient care, it will still follow the money. Most of us work at a place that might be the largest employer in the state we work at, in the county for sure. And all of that, we can't shy away from understanding how to lower the cost of care because it impacts the affordability for our patients. And I might say that creating affordability is as much of an empathetic process as everything else we're trying to do as patient experience leaders. So I think thinking of value-based care, thinking of being the connector in our roles from the provider to the payer side, understanding where they both could be aligned. Usually they want to raise quality. Almost always they want the experience to be better and certainly want the cost to be lower. So there's a lot we could do. And I feel like safety, quality, patient experience leaders are that key person in between the payer and provider that can make that narrative come to life.
Let's take a few questions from those listening remotely. We've got a few questions here. First, from Gina Lehman. I love your efforts to improve ease to get care. I'm curious as to how you're measuring time to treat to focus your improvement efforts. Are you able to measure beyond your internal network patients?
Great question. We were just talking about this measurement. I'll start with the last one, Gina. Time to treat. Where we do this well is our oncological service. So where there is either a new diagnosis of cancer and needing to get chemo or a concern for cancer and needing to get like a radiology study or biopsy done. I think we measure that well. It's interesting in our other global partners and also places like Abu Dhabi and London, they're held more accountable nationally to their time to treat measures. So we're learning a lot from them around transparency around time to treat measures. And again, human suffering right in that time and preventable harm. Those days and minutes matter to our patients. So mostly in our oncologic, of course, in our stroke and some of our ED measures, we measure it. Not much more transparent currently than within our walls in our system. But that's a great opportunity nationally for us to go. Where is that measure and where is it required for us to work together on improving that? So that's time to treat. Back to ease, how we measure ease to get care. We've been asking this since 2020 on our patient experience surveys that we send out. So you can add some questions, of course, to the typical subset of those inpatient patient experience, but we ask it from the surveys we send from our inpatients, from our ambulatory lab and radiology, and our emergency department. Each of those surveys methodologies have that question about how easy it is to get care at the Cleveland Clinic. And so that's what we're trying to improve.
We've got another question from Jonathan Recky. A moment to care sounds so powerful. Great example of recognizing the human in every person. Is there another example of how the Cleveland Clinic goes above and beyond other healthcare providers in recognizing the patient as a whole, mentally, physically, emotionally, and spiritual person?
I think there's many of different things. I'm trying to think of some that we've hardwired around our care. I think one, which sounds, as I'm thinking, which might sound a little corporate, but one is absolutely access to their medical record. So a couple of things that we do, and many organizations do this, but one, we're finally all on the same instance of our Epic medical record. That's a big deal for patients. Mm-hmm. To have everywhere they go within our system, that same instance, and they can follow that along with, of course, their MyChart with their portal. The other thing we do, we release all metrics, all labs, radiology right away. There's a lot of, debate on how good we've done that for a long time. We feel like empowerment of our patients with information is respectful, and that's been our choice to always release everything in a timely manner. So some of our, I think our processes around transparency and being and kind of digital access, I think have been really, really good for our patients. And I love an empowered patient. They're the safest patient in our healthcare system because they have the most knowledge and they care the most about themselves. So that's really our mindset.
Yeah, I think that's the future of technology, is that the degree to which we can put administrative things, on the technology so that we don't have to spend the precious time we have between patient and care provider on that stuff. It should free up more time for the interpersonal, emotional things in that relationship. We've got a question about leader guided discussions from Rutwa Nake. Are leader guided discussions done during staff meetings or by utilizing some other platform?
Yeah, good question. It's both. So those that have kind of staff meetings and want to intertwine it, they're absolutely allowed to. Other things are done by huddles. We gave the leader, because we had the measurement and kind of the loop accountability of them happening, we gave the leader some leeway of how, when, and how they wanted to do it. They just had to have that conversation within the kind of that same month time span. So usually it's a huddle. Some leaders that their huddles are too short, they'll do aspects of it for 5 days in a row over a weekly huddle. Aspects of the discussion, they might take a tool, talk about it for 5 minutes. The next day they may take. So we really gave them some fluidity on that.
Another question that we've been hearing more often each month. Could you please discuss the involvement of the patient's family in experience improvement?
And I want to give a shout out to a company called Q Rounds. They're just kind of starting, but hopefully you can find them. It's a really great idea. So one thing we've been challenged with as far as families is really the matching. So I talked to you about plan of care visits. Physician, nurse, care team at the bedside with the patient and hopefully the family. That's the moment everybody's waiting for in their hospitalization. Our patients will wait all morning long because they heard rounds would be in the morning. They don't take a shower, they wait. Their family member doesn't go to work or doesn't go down to the cafeteria to grab a coffee because the doctor is coming. And so what we're really trying to think through is, now that we've established this is how we care, right? A team comes to the bedside every day and talks to our patients and they understand the plan of care. And of course, we want the families involved. Time transparency around that and how to do that. So our family members could get text and could join from work if they wanted to. And our patients, certainly the ones that are alert and able to, could get some awareness. And it's a bit of a matching, right? Doctor's going to plan on coming to rounds. This is the order he or she is going in. Here's how the nurse matches up. Oh, we need an interpreter. Let's match them up. Here, let's bring in the family. That to me is the next moment of eureka. Believe it or not, I know everybody else, Amazon's figured it out. DoorDash has figured that out. Healthcare's not figured that out yet, that time transparency. So Q rounds might help us. We're going to try to figure that out to bring the families involved. We think it's a huge component, especially on that day of transition of care. If they're leaving our hospital, that is the most important plan of care visit, that day they leave, and having the family there as a key partner is important.
Yeah, the plan of care sounds like a great innovation in terms of how you care. And so that's fantastic. The challenge, I suppose, is the coordination and the logistics associated with making that happen.
Yeah, it's not that any of us don't want to do a plan of care visits. I'm speaking for me as a provider because I still see patients. It's logistics. It's finding the right nurse and getting all together and then making sure you have the physical therapist there because their input is so important. So that's exactly what we're trying to solve for.
Terrific. I've got time for just one more question for you, and it's my favorite at the end of every program. Do you have a favorite quote that you can share with us? And if so, why is it your favorite quote?
I do. So lately, I don't know, I've been just excited about Dolly Parton, maybe because she's just fabulous and she just keeps going. So I found a quote from her lately, and it's, the way I see it, if you want the rainbow, you got to put up with the rain. So that's Dolly Parton. If you want the rainbow, you got to put up with the rain. And I really liked that.
And why does that have such meaning for you in particular? Because is it because we often want to avoid all the rain in our professional lives or our workplace, or we just have to kind of accept, that, the only way that rainbow has as much meaning is when, we've got to put up with some rain.
Yeah, I think it's healthcare is hard. It's really hard right now for all of us that work in it. Of course, it's hard for our patients that are suffering. And so in general, I think it's just thinking through, you just got to push through those rainy days and know that you can get to that rainbow and you can get to something better and improvement that inspires us all on why we do what we do in either healthcare leadership or in bedside care.
Outstanding. Dr. Jurecko, we greatly appreciate your time and insight today. Thank you for contributing to our conversation on humanizing healthcare. You and your team are making great strides at the Cleveland Clinic, and we look forward to following more of your accomplishments in the future. To our listeners today, thank you for joining us as well. We hope you found this discussion informative and inspiring. So be sure to join us next month for our Humanizing Healthcare discussion with Dr. Adrian Boise, Chief Medical Officer for Qualtrics. You won't want to miss it.